So the topic today, we really need suggestions, but I think somebody suggested syncope, which is reasonable, and I'm gonna touch up on antithrombotic therapy after PCI. So let's start out talking about syncope. So if you really look at the American adults, you're gonna have between 30 to 40% of people will have at least one syncopal episode throughout their lives. You guys can hear me well, right? Okay. Um, so so at least 30 to 40% will have syncopal episodes, so it's pretty common. Just just to keep in mind also, about 40% of syncopal episodes are idiopathic. You cannot identify the etiology, and you cannot identify the source of syncope. Also remember that as we get older, the syncope may be related to cardiac etiology. So if you divide the syncopal episodes in terms of etiology, you have the vasovagal or neurocardiogenic syncope, which is the vagally mediated syncope. You have the cardiac syncope, and then you have the non-cardiac syncope, which could be related to neurologic or seizure disorders and so forth. The vasovagal syncope usually does really happen in younger patients who are otherwise healthy, gets exacerbated by hypovolemia, sometimes is related to uh, stressful events, and sometimes just you cannot really tell about the timing. You cannot actually predict the reason for the syncopal episode, but in general it happens in younger patients, it happens in healthier patients, and usually patients will have some time, they start having tunnel vision, a little bit nauseous, about to vomit, and sometimes they even actually smell stuff, or they have changes in sensation or visual changes, and then they pass out. So usually if they tell you, hey, I was driving and then all of a sudden I start feeling bad, so I have to actually pull over and stop, and then all of a sudden I passed out, that most of the time is vasovagal syncope. Usually it's benign. Treatment for vasovagal syncope is hydration, and if you feel that hypovolemia or hypotension is part of the issue, you can actually do either midodrine or fludrocortisone to encourage hydration and increase blood pressure. The other causes of syncope, cardiac or cardiovascular, that includes orthostatic hypotension in patients who sometimes actually double the medications. So when they stand up or just de novo, they just get passing out episode when the blood pressure goes down. Sometimes actually heart arrhythmias can be the etiology, is Brady or fast heart arrhythmias. Cardiac syncope usually is sudden and predictable in elderly patients. So if you have somebody who's a little bit older having syncopal episode above the age of 50 or 60, always you have to investigate. And you have to investigate cardiac etiology. Sometimes sinus pauses, sometimes intermittent complete heart block, sometimes ventricular tachycardia, ventricular torsades, episodes of torsades, fast SVT, fast AFib can give you this kind of syncope, and usually in the elderly patients, and always investigate about the etiology, especially in somebody with CAD disease or previous cardiac issues such as atrial fibrillation or heart arrhythmias. The non-cardiac syncope, non-cardiac etiologies or causes for syncope There are a bunch of them, and if we're talking about seizure disorder, in that case, it's not going to be really syncope per se, but it's going to be loss of consciousness. But nevertheless, there are other etiologies besides cardiac, and stuff related to the brain. And if you feel that the patient is old enough to have something pathologic and you don't identify anything cardiac, then neurological evaluation is not reasonable. But always remember that the older the patients, the older the patient, the higher the likelihood that the syncope is from something organic. And remember also that about 30 to 40% of syncopal episodes are idiopathic. So if somebody comes to you, okay, why did they pass out? Oh, I don't know. There's 40% of syncope you'll never be able to identify the etiology. In fact, syncope are one of the most expensive ER visits. And with syncope, even though we order carotid ultrasound, but is really not, carotid ultrasound is not really standards of care. So you're blocking one artery, you're not going to have syncopal episode because the other artery is going to be open, and the other vertebral and basal arteries are going to provide enough blood supply to the brain not to have syncopal episode. But we do order that all the time, but it's really not included in the standards of care. And that's against what the common belief is, especially in ER physicians and in hospitalists and primary care physicians. So for your patient population, syncopal episodes, you should really investigate, and I would do at least echocardiogram and telemonitor. Now, remember that sometimes sleep apnea may, instead of having syncopal episodes, sometimes actually elderly patients, they just fall asleep, and that's really not syncope. Just, be careful about that. I'm going to go quickly over antithrombotic therapy. So antithrombotic therapy includes antiplatelet and anticoagulation, right? After PCI. So remember that nowadays the stents we have are pretty good. Even if you have actually acute myocardial infarction, so the dual antiplatelet therapy is indicated between 3 to 6 months, regardless of the stent. And if you have somebody with atrial fibrillation or another indication for anticoagulation, you do single antiplatelet agent only. And I would do either Brilinta or Plavix or Efient, and then for the first 3 to 6 months, and then if you're gonna just continue with aspirin only, and anticoagulation therapy is reasonable. But the dual antiplatelet therapy after PCI is indicated for 3 to 6 months only, and then antiplatelet therapy in the case of another indication for anticoagulation, and you have either warfarin or of other medications on board, then the treatment is going to be single antiplatelet agent and anticoagulation. Less medications, less is more, especially in your patient population, the elderly patients that we have. Less is more. Keep that in your mind. And if you feel that your patient has even PCI, and then his hemoglobin or her hemoglobin is about 7.58. In that case, you can even drop the dual antiplatelet agents and stay on anticoagulation, smaller dose. So just keep that in your mind, that the stents are becoming the scaffold of the stent becoming less thrombogenic. So you don't have to have a lot of antithrombotic agents to prevent stent thrombosis. In fact, there's data right now validated actually in the New Journal of Medicine. It didn't make it all the way to the guidelines, that single antiplatelet agents such as Brilinta or Efient could be enough in patients after PCI with acute myocardial infarction. So you don't have to have antiplatelet therapy from day one. So just keep that in your mind, and do not late. When that happens, at least once I've seen in one of the patients at one of the facilities that patients aspirin Plavix or aspirin Brilinta and anticoagulation. That's a mistake. If the patient bleeds, we're going to be, that's not smart. So just be careful about that. And always remember, especially in these elderly patients, they have anemia by default, that less is more and less medications is better. And, these guys who do interventions, they tend to really, unfortunately, they don't really look at the whole picture. And I'm not really criticizing, but I can tell you that if probably you've seen it where surgeon want to stop antiplatelet, antithrombotic agents for like week or 10 days. And then the cardiologist, interventional cardiologist want to keep as much as antiplatelet, anticoagulation medications as he can squeeze in. And they really don't look at these patients. They are fragile and they have a lot of other comorbidities, and these medications are not really indicated. So be careful about that. Any question?
Can you hear me, Dr. Ibrahim?
Yes, Ali.
Hey, so I'm seeing like a moderate resurgence of digoxin, and I know you don't care for that. So
No.
yeah, so changing them over to amiodarone, is that the way
Yeah,
to go?
yeah. I think if you want to do amiodarone for rate control, the beauty about amiodarone, it provide beta blocking activity. It does not affect the blood pressure too much, and it really does control the rate to a certain degree. What you have to remember is this, that uh, that if your patient is elderly and you don't care about amiodarone toxicity 5-6 years from the time of initiation of medication, that's reasonable. And if your patient is ill enough that you gotta do something, is reasonable. I really do hate digoxin. Digoxin has very long half-life, between 24 to 32 hours, and digoxin is renally cleared. And digoxin also, when you use this medication in these elderly patients who are fragile, who are tiny, who have changes in their kidney function, unpredictable, especially if they are taking diuresis, so that might change their filtration, and that might actually precipitate your patient to digoxin toxicity. It did happen to us. I hate this medication with a passion. And one of the facilities, somebody, I've seen patient was having a bunch of PVCs and ugly looking PVCs, right? And you can tell that this is probably some kind of digoxin toxicity or something going on, or ischemia or something. And then it turned out that patient was on digoxin and nobody picked it up to adjust the dose or stop medication as the kidney function is changing. So I really hate this medication. I've used it and I continue to use it acute settings. Let's say you're at Kindred and your patient is 150 and blood pressure is 80. So give him 0.5 of digoxin until, whatever sepsis, whatever stuff, gets the, buy you time to see the natural history of the disease. Is going to go full-blown sepsis, or the antibiotics and the fluid is going to work. So I would give digoxin 0.5 and probably repeat another 0.25 or even 0.5 12 hours or 6 hours later. But I would never listen. When I was in training, one of my attendings told me, don't ever put an order for continuous potassium medication to be given, because he died actually not a long time ago at age 97. And he said that back in the 50s and 60s, the number one iatrogenic cause of death was potassium infusion. I didn't know that. And I really feel the same about digoxin. I think digoxin, if you don't really monitor the medication, and if you're seeing 30 to 40 patients a day, you're not going to remember that Mr. John Smith on digoxin, and you got to adjust the dose, and you got to, check the digoxin level, and you got to make sure that potassium is normal, right? If your potassium is low, that will enhance digoxin toxicity. It's a lot of stuff, you're not gonna get the same reward for your buck if you use digoxin. And is so much toxicity associated with digoxin. It did appear in the guidelines before. Now we're really trying to avoid it as much as we can, unless you have congestive heart failure and it's class 2B indication. So I wouldn't use the medications. It's risky.